and welcome in nursing webinar session. Myself Shanti, and today we are going to talk about a very prevalent topic on total shoulder arthroplasty. It has been a very great honor and privilege to share this session with the very marvelous and eminent expert panelist, Dr. Deepti Nandan Garu. He is our senior consultant, orthopedic surgeon, clinical director, and highly skilled specialist for shoulder, elbow, and sport injuries. And he's from High Tech City, and he's been elected as a president for National Shoulder, Elbow, and Hand Society, and it is a very proud moment for us. I welcome you, sir. Thank you for the webinar invite.
Thank you very much. Thank you very much. That's kind of you to give me that introduction.
Thank you, sir. And let me also welcome Ms. Sujata, who is our senior nurse manager from Yashoda Hospitals unit, who is also very able and crisis champion. I welcome you, Sujata.
Thank you, Shanti ma'am, for giving me such an opportunity, and welcome to my dear viewers, and have a great talk.
So today we are going to talk about, you can start sharing the slides as well. Today we are going to talk about the very third most, musculoskeletal condition called shoulder conditions. And I think 70% of this disease burden seems to be very increasing in among Indian population. So here I would like to have as experts' opinion on why this prevalence is very high, and is there any age limit, sir? We'd like to have your opinion on the same.
See, arthritis of the shoulder is second or third, as you said, is right. It is after the knee. Knee is more common in India. Hip is the second one, and the third one is shoulder. The problem with shoulder arthritis is that it's not been recognized very often in the general public, and because the thought of having arthritis in the shoulder is not there. That is why they are not recognized. But when I see them in the clinic, it is not as less as it's been reported as in most of the Indian literature. In the Western literature, it is the third most commonest. Obviously, we're excluding spine problems. As far as pain in the shoulder is concerned, it's a very common problem, and it can start right from 20 years of age to 90, 80 years of age also. Most of the time, the problems you get after 60 are because of arthritis. But the ones you get before 60 are either because of the instability of the shoulder. That means the shoulder joint popping out of its socket frequently happens more below 40 years of age. And after 40 to 60 years of age, it is mostly rotator cuff problems. Means the muscles which control the shoulder get torn because of degeneration with age. And when there is a tear, that sometimes also, when it progresses to a very severe degree, can cause arthritis of the shoulder. Okay, so shoulder arthritis is not as uncommon as we all think it is. Just a simple X-ray can diagnose that problem.
So let us see what we have in the rest of session. Over to you, Sujata, for the second slide.
Yes, ma'am. The shoulder arthroplasty. It means the damaged part of the shoulder bone will be removed and it will be replaced with the metal and plastic material. That is we called as a shoulder arthroplasty, ma'am. And this is the normal anatomy of the shoulder, ma'am, joint, where it is the thing actually. This is a ball and socket joint, kind of socket joint. The round.
Your slideshow is not seen, Sujata. Sorry to interrupt. The slideshow.
Yeah.
This is
Make it a slideshow. Press on the slideshow.
Still we can't see, just. Share the screen.
Yes, ma'am. Sharing, please.
Yeah.
Sorry for the interruption.
Yeah,
and this is the shoulder joint, where we can see the shoulder is a ball and socket joint. The round head of the upper bone fits into the shallow socket. Is the shoulder joint actually. And this is the, here we can see this in next picture we can see clearly the articulation, the movement of the shoulder joint, how it was takes place. It is actually including of three bones: acromicrobial joint and glenohumeral joint and SC joint. All together, if it is coming and sitting together, then only the articulation will take place.
So, sir, we, as you said, that because of rotator cuff tear and post 40, there is arthritic condition or post traumatic arthritis. Uh, is there any physical exercise which will keep this condition away, or do you suggest what could be the preventive regimen for this to prevent this condition?
For the rotator cuff, if you are a sportsman, especially overhead sportsman, then you should do exercises to strengthen the rotator cuff. Most people, when they go to the gym, they tend to strengthen their deltoid muscle, which is the outer muscle, because it's obviously seen. They want to show that off, and so they strengthen that. The rotator cuff is a muscle inside the shoulder, which is not visible, so we don't tend to concentrate a lot on it. The function of the rotator cuff is to hold the ball into the socket in the center. So when the deltoid works, it will pull the arm up. That is what the rotator cuff does. So if there is a tear in the rotator cuff, then the hold of the ball on the socket is not so good. That is why it might lead on to arthritis. Now, to keep that healthy, there are very specific exercises for strengthening the rotator cuff. And many a times a physiotherapist can help you learn those exercises correctly. So if you do those exercises on a regular basis, then the ball is centered on the socket and the stress on the joint is lesser. So the joint is more healthy.
Yeah. Okay.
And this is the signs and symptoms which is faced by the person is especially the pain is the most probable symptom, and swelling, stiffness of muscle, and skin discoloration or bruising, and limited movements, that is range of motion will be decreased.
So can I just mention about the pain? Pain, shoulder is a very sensitive joint. When you're cold, what do? You put a blanket on your shoulder. So because it's a very sensitive joint. So it's very painful. A lot of times people with a painful shoulder will come crying. That is how the bad pain is. If the pain is at night, then think of a frozen shoulder or an arthritic shoulder. If the pain is only when you move your arm, more likely to do with a rotator cuff problem. Okay. And limited movement is the most important thing we look for, because in an arthritic shoulder and in a frozen shoulder where you have inflammation in the joint, the movement in the shoulder joint is reduced. So they'll have difficulty combing their hair, putting their, having a bath and everything else. With the legs, it's only walking, but in the arms, unless the hand comes to your mouth, you cannot function. Okay. So it's very important to look at all these aspects, not just pain. That's it. Okay. Thank you.
Yes, sir. And next, coming to the indications, in these all conditions, we can go for the shoulder arthroplasty, and especially rheumatoid arthritis and rotator cuff tear, arthropathy and avascular necrosis and post-traumatic arthritis, which we can see clearly in the picture, and severe proximal humeral fractures. In these all conditions, we can go without any doubt for the shoulder arthroplasty.
So do we also see any other indications, sir, as per your
So these
opinion?
are the main common indications we see. Okay. In all these conditions, the common factor is the socket, the cartilage lining the socket is worn. The cartilage lining your humerus is also worn. That smooth lines you are shown on the X-ray, the green and the blue, they are gone, and the gap between the two bones come together. So it becomes very irregular. So every time you move, they can feel a cracking sensation. So whenever the surfaces are worn, we change it. In avascular necrosis, the blood supply to the head is lost. And that is what we've seen in COVID patients. It's more common in the hip, but avascular necrosis also happens in the shoulder too. And when the head is damaged and the shape is altered, we have to change the joint. But when there is infection, you should not be changing the joint. Any artificial joint replacements are not done if there is infection.
Even during the tendon inflammation, bursitis also we cannot.
No, bursitis and inflammations are not indications for arthroplasty. Only when the socket and the ball is worn down, you do it. Bursitis are all soft tissue problems around the shoulder. That's a different topic altogether.
And next, this is the picture which is operated by sir. And this is the first film we can see the patient is with multiple shoulder problems. And in the second picture after post-operative state, the patient is able to give full range of movements, which we can see clearly.
This X-ray you see is a shoulder joint, total shoulder joint replacement. You see the ball is changed of the humerus. The original ball is not there. And you see the other white metal which is there. That is the component we put into the arm bone so that the ball can sit on top of it correctly. And on the socket side, you see there is no metal there, but you see a small dot, a white dot. That is where the pegs of the glenoid, the plastic glenoid goes in. So you'll have plastic on the socket and a ball on the arm side.
Arm side, yes.
Arm side. And this is done when the rotator cuff is normal, but only the joint is worn down. And you can get good function out of it. People think that you don't get good function of an arthroplasty. That's wrong. If the right indication and the surgery is done properly, this is actually my aunt and she has full range of motion in the shoulder. She's been 7 years down the line now.
Great outcome, yes, sir.
And in this picture, there are types of arthroplasty and modalities and types. This is first picture is this hemi arthroplasty, and second one is total shoulder, and it is third one reverse total shoulder replacement, which is operated.
So, sir, these modalities, when one should, seek, like, what are the indications of any?
Arthroplasty means only the ball is changed. Means the socket is normal. When do you get it? When there is a fracture of the ball and we cannot reconstruct the ball. So we put the metal ball in it and reconstruct it. Okay. In a total shoulder, when the socket and ball are worn down, then you have to change both the socket and the ball. Now you could say, why not do the same why is the last one there? The last reverse shoulder. Because for the ball to stay on the center of the socket, I told you the rotator cuff should be intact. But if you have a tear of the rotator cuff, which is not able to hold the ball on the center, the whole ball will start shifting up because the deltoid will start pulling the arm up. So you need a prosthesis where instead of pulling up, it should rotate around it. That is why we put a ball on the socket side and the socket on the ball side. So now when the deltoid is working, it rotates rather than going up like this. That is the difference. So that is a reverse shoulder. Why is it called reverse? Because the ball is on the socket side and the socket is on the ball side.
Ball side.
Yes.
So is this a very safe procedure, I think, and it is getting a lot of popularity and patient feedbacks are very, very great about it.
It is safe, but the training in this is not, it's been limited. So the reported outcomes in Indian situation sometimes are bad. And even in the best of hands, the complication rates for a reverse shoulder replacements are much higher than the regular knee replacement and the hip replacement. So a proper trained doctor, if you do it correctly, the chance of complications are very low. This at least you should be. There are studies which have looked at how many cases you need to do. So if you have done at least 20 or 30, then you can do a safe procedure. They have looked at 200 of his cases and they found that the first 20, 30, they had a lot of complications. After that, the complications will reduce. It's like anything in life, you keep doing it, you're getting better at it.
Yes. Yeah.
And next, this is the image of that osteoarthritis and arthritic shoulder.
As we have discussed previously.
So there is the shape is altered, there is extra bone forming there is arthritis in the joint, so it's not smooth any longer. And this gentleman, you see the ball is also moved up.
Yes.
In this picture, that means the rotator cuff, which is supposed to keep the ball in the center, is not working. So in this situation, you have to do a reverse shoulder.
Reverse shoulder.
Reverse shoulder.
And this is the difference between the hemi arthroplasty and also total shoulder arthroplasty. And this is the hemi arthroplasty is coming to this easy procedure and short operating time and less risk of instability, and can be revised with the total shoulder arthroplasty and less reliable pain in relief. And it is coming to a total difficult procedure, longer over time, and polywear can be used, loosening of the both components and more glenoid bone loss, and there may be more consistent pain relief also can be felt.
So in better than hemi arthroplasty is total shoulder replacement, because on the hemi you have a ball and a socket. The socket is bone and this is metal. So when metal rubs on the bone, what happens? It starts wearing down. When we started doing shoulders replacement, we used to do only one side, and 10 years down the line, we noticed a lot of these patients were having pain. So we had to revise them into other shoulder replacements. Means the socket also had to be changed. So now we are thinking it's better to do a total shoulder. So if you see that last line, hemi arthroplasty gives less pain relief reliably, whereas a total shoulder will give you a better pain relief reliably. Okay. So it's better to do total shoulder Obviously, it's a more complicated procedure and you need good training for that. And you do only hemi when you think the patient will outlast, sorry, the component will outlast the patient. That means in very elderly patients where you cannot reconstruct the bone.
And this picture is this is an international patient which is operated by sir, and in the post-op we can see full range of motion we can see.
Yeah, this gentleman is a CT scan you saw earlier. That is this gentleman's. And we did a reverse shoulder replacement. He went back to Canada, and this is a photo he sent from Canada, from his boat. He lives on a boat, so he's able to do everything. He's delighted with his results.
So even the revised total shoulder arthroplasty also can be, if that sometimes maybe that can also be a criteria for revision sometimes, sir? No.
No, if this shoulder replacement is loosened, or if that component comes loose, then we do a revision. Means we take out these original the other components and put new ones in. But it's always very tricky to do a revision because the amount of bone you see on the scapula is very, very thin. So if that bone is lost, I don't have anything to fix that bone onto this component. Whereas in the knee and the hip, there is a lot of bone available. So even if it goes this way, that we can still get it right. But in the shoulder, for margin for error is in millimeters.
Yes, yes, yes.
And now we are coming to pre-operative checklist, which is taken care by the nurse. These things are to be included in this, and we have to keep the patient on nothing by mouth from 12 midnight. That is 6 to 8 hours of prior surgery, and also including pre-anesthesia checkup must be done by the anesthesia doctor, and also the site marking must be done at same time, and also the patient must be parts preparation to be taken care well, and these are all the parameter which we have to include in this pre-anesthesia checkup. And also
Can I just
concerns.
mention about the part preparation? We have a lot of emphasis on part preparation. I would recommend not to do too much of part preparation. In the shoulder, we only look at the axilla. So if at all, only a trimmer needs to use for removing the hair, and that has to be done in the preoperative area or preferably in theater itself, and then do your prep. Now, very common infection we get in shoulder replacements are from the bacteria which are there in your armpit. That's called the propionobacter. And propionobacter is very sensitive to chlorhexidine. So all my patients will get a chlorhexidine wash 2 to 3 days prior to her surgery. Okay, in the axilla, and you have a shower. And we also prep it with chlorhexidine with alcohol prior to surgery. So it's very important to do this before any shoulder replacement because that will reduce the risk of infection in a shoulder replacement.
Yes, sir. And this is the slide we can see the IPSG goals plays very important role in the surgery of the patient. That is identify the patients first correctly at the time of taking the patient for which is planning for surgery itself. You have to take care of your patient. That identification must be done in such a way. And also the communication must be effectively and improve the safety of highlight medications and ensure safe surgery. And this is what we have to do, site marking at the ward level itself. Then we have to wheel to the patient into the OT. And then the risk, then if you prepare your patient at this level, then the risk of high hospital acquired infections also can be calmed down. And also you can you can take care of your patient resulting from fall also at same time. And this is the time we have to play the IPSG goals must play the great role. And this is a pre-op care where what all things we have to look into is that PAC, pre-anesthesia checkup must be done and consent must be obtained, and surgical profile with any kind of screening which is required investigation must be there minimum. And also NBM for 6 to 8 hours is very important, and site preparation which is advised by the sir, and arrange all images and blood reports along with the patients and the resulting to be hand over to the pre-op OT nurse, and also administer prophylactic antibiotic that may be in the ward level or in the OT also recommended, and hand over to the pre-op nurse from ward to OT. Yes.
So as you have already mentioned, site preparation with the chlorhexidine scrub and
Yes,
prior to the surgery. Yes, continue.
yes,
And the antibiotic is very important because you give it at least 1 hour before the incision is made. So don't just give it just before the surgery, but it's better to give it in the pre-op area and then wheel them in.
yes, sir. And next, this is after, if once the patient is operated, then what is the nurse responsibility immediately in the post-op recovery area? That is including receive the patient in comfortable position, give the comfortable position which shoulder will not affected, and check for hemodynamical stability, including all vital parameters. We have to look into that, especially BP, temperature, pulse, and respiration together. And also the fifth vital, as it is pain assessment must be done at earliest, and also pain analgesics and reassessment of the pain also must be taken care at same time, and ensure arm pouch is placed as per recommendation of the doctor, and range of motion restriction as per the surgeon's order to be taken care.
So arm pouch, I think we always keep this arm pouch for the patient. And how long this has to be worn, sir?
See, the reason we give an arm pouch support for a shoulder replacement is because when we go into the shoulder, we cut a muscle called the subscapularis, which is one of the main muscles for the rotator cuff. So rotator cuff has one muscle in the front, subscap, one supraspinatus on top, infraspinatus and teres minor at the back. So when we cut this muscle and then repair it, we want that to heal properly onto the humerus. Otherwise, the ball will not hold centrally again. So for the healing to happen is about 4 to 5 weeks. So that is the time we keep the arm pouch, but the patient is advised to take it off intermittently. You can eat with the same hand. You can do a little bit of brushing, and all these things are not a problem. As long as the arm is not taken away from the chest and you're not doing this sort of movement, you're okay.
Also,
So you can
patient
still do your normal activities, cannot lift weights,
Yes.
don't sleep on that side. Ice packs are a very good idea immediately post-operatively. So that is something you should do. And one other thing importantly from nursing point of view, we should remember is that we should have a pillow behind the shoulder going down the arm. Because see, our body's thickness is this much. So when you leave the arm will flop backwards. When the arm flop backwards, you'll have a lot of tension in the shoulder in the front. So, but if you keep a pillow behind the arm, it will rest the muscle in the front and it will be relaxing for the patient.
And
Okay,
healing.
that is a very important thing, and ice packs are very important.
Yeah, as well the healing, yes.
Yeah.
Very good point, sir. We urge all the nurses to just follow the instruction as sir is has rightly mentioned, that pillow to be placed underneath the shoulder where the area is operated. Yeah.
And there are possible complications that may be different with person to person, and we may see, we may not face sometime, and thus that is dislocation and implant loosening also may seen sometime, and fractures and rotator cuff failure and nerve damage, blood clots along with infection sometimes.
So I
So
think
as far as the dislocations are concerned, immediately post surgery, so the precautions we need to take when you are nursing them is don't hold the arm and lift them. You can put your arm under the axilla and hold the chest and lift them up, but never pull the arm up. One. Secondly, when they are lifting up from the bed, they should not put their arm like this and try to get up. If they do that, they might sometimes dislocate the arm. You can keep it on the chest, no problem. You can lift it up like this, no problem. But do not try to load it when you're getting up. Any blood clots which are there inside the joint can also sometimes dislocate. So if somebody is having bleeding problems and all, please inform the surgeon so that they can take care of that part. And the blood clots is a very important point. You put it in red, and that is aptly so, because we all think that we get blood clots only when you do knee replacements and hip replacements. But blood clots can happen even in upper limb surgeries. The risk is very, very low compared to the other two. But giving anticoagulants and making them mobile as much as possible is very important. The most important thing in any upper limb surgery is to give them enough hydration. We have a tendency to give IV fluids a lot. Once the anesthesia effect is gone and they can swallow comfortably and they're safe to swallow after 2-3 hours after the general anesthesia, it is good to encourage them to have oral fluids rather than IV fluids.
yes.
Because IV fluids can do overloading in elderly, because most of the shoulder replacements are elderly people. And they are often 10 years older than a knee replacement patient. Okay. So they have to be very carefully managed. If they get overload of fluids or any problem with their electrolyte disturbances, then they get into major trouble. So these are simple things, and always give them normal diet post surgery. The second most commonest complication we see on the wards is the constipation.
Constipation.
So we need them enough hydration normal diet, that problem will be less.
Yes, sir. Absolutely right. Yes.
And infection, we don't need to give antibiotics for 5 days, 6 days post discharge. We only give antibiotics for 24 to 48 hours maximum. That's about it. We do not give oral antibiotics home. So please do not send them home with oral antibiotics.
Sure, sir. And this is the now the surgery part is done, and the orthopedic surgeries and most post-operative period, which is the physiotherapist plays a great and important role here. And these here we have to take care that immediate mobilization of the part to be done, and start with pendular movements and slow abduction movements at the time of immediate post-operative. And the discharge advice, coming to discharge advice, that is physio exercise as per the instructions, and review after 1 week can be given at the discharge advice. And then post discharge instructions, there are different type of things we have, and week 1, week 2, what all things we are supposed to take care. At the first week we should take care of 120 degrees of flexion forward and 20 degrees of external rotation, which we can see in the pictures. And also in second week, 140 degrees of forward flexion and 40 degrees of external rotation, including 75 degrees of abduction with 0 degrees of rotation. And the row must be at least 140 degrees of forward flexion must be done, and 40 degrees of external rotation and 75 degrees of abduction. These all as per the physio and consultant together we have to take care of the thing.
So very important to get the surgeon's input, because this will not be the same for every patient.
Yeah.
So we have to be deciding this based on the bone quality, the repair quality and everything else. But most of the time we start the movements, the forward flexion, everything beyond 3-4 weeks. We don't move them as much in the initial phases. Okay, so it's always better to take an input from the surgeon itself for this sort of regime.
So these criteria has to be followed from 4 to 6 weeks, I guess, and the patient should abstain from work. Yes.
So first thing is the muscle should heal.
Yes.
Then we should increase the movement in the joint.
Yes.
Then you increase the strength in the muscle, which is moving the joint. So it goes in phases.
Yes.
The last phase is strengthening, which is TheraBand exercises and everything else. The physios will direct the patient how to do it.
Yes, sir.
So yeah.
And this is the then we are coming to contraindication. In such situations we should not go for the shoulder arthroplasty. Those are active or recent shoulder joint infections and paralysis with complete or loss of rotator cuff and deltoid function, and neuropathy and arthropathy. And in such situations we cannot it is not advisable always to go forward.
True.
Yes, sir.
Yes, absolutely agree. Not complete loss of rotator cuff, but paralysis of the deltoid, definitely no. But loss of rotator cuff, we can still do a reverse shoulder because deltoid is working. But neuropathic joints like Charcot's joints, don't do an arthroplasty. They're disasters. They fail. I've seen them fail badly. So don't do them.
So that was very simple and very great session. Very fantastic information you have provided to us, sir. And as a part of the preventive strategies, would you like to just conclude what could be the prevention parameters?
If you look at prevention in arthritis, most of the time arthritis is genetical. Means you have some genetical problem where your cartilage wears down fast. So you get arthritis in the knees or shoulders or anywhere else in the body. So you cannot really prevent that. We can only be active, keep the joint mobile, so the joint is healthier and it takes longer to wear down. One. Second thing, if you're looking at rheumatoid arthritis, most important thing there is that if we can identify rheumatoid arthritis at a very early stage, when you get inflammation, that means stiffness in the joints and everything, go see a rheumatologist. And if you control the inflammation in the early stage of the disease, you will not go in for a replacement of the joint because the joint is preserved. So very important to recognize inflammatory arthritis early and treat it early and maintain the treatment. Most of the time we get deviated about this therapy, that therapy, and we actually don't treat the inflammation. In rheumatoid, the inflammation eats the joint. In osteoarthritis, the cartilage is worn down, then you get inflammation. So in rheumatoid, joint deformities can be prevented if it is treated early.
Thank you, sir. And we have come to the end of session. And every Thursday we will again stay tuned. We'll connect back again. Thank you so much, sir, for your very valuable time. Thank you, Sujata.
Thank you very much. Good.
Thank you.